Good afternoon and welcome back to our afternoon sessions for the Maine Public Health Association's 2022 annual meeting. I hope you're able to get outside for a bit on this beautiful fall day. My name is Becca Bolis and I'm Executive Director at Maine Public Health Association, and I am going to be moderating today's first session of the afternoon. We are having a plenary panel defining, assessing, and addressing rurality and public health. A couple of reminders before I introduce our session moderator. The first is that we're offering closed captioning services. Within the session, you will automatically be provided with captioning, which is underneath the video stream. You can click the link to access it in a separate window if you prefer. And if you don't want the captioning service, you can push the pause stop button and it will stop. The second item is to please be sure to complete the session evaluation. It's very short, but your feedback is very helpful to us, and it is required if you're seeking continuing education credits. You can find the evaluation in the session description, and I'll add it to the chat. You'll also get a reminder at the end of the day with links to all of today's session evaluations. So with that, I am excited to introduce our panel moderator, Tim Cowan from Maine Health. And Tim, I will turn it over to you to introduce the rest of the session and the panelists.
Great. Thanks, Becca. Good afternoon, everyone. I'm really excited to learn from our four public health colleagues today. I'm going to introduce them in order of how they will talk. So first, we'll hear from Erica Ziller. Erica is an associate professor at the University of Southern Maine. Then we'll hear from Tom Judge, who's the executive director of Life Flight of Maine and a member of the Rural Health Action Network. Sabrina Keene will talk after that. Sabrina is a program coordinator at the Healthy Community Coalition of Franklin County. And then finally, we'll hear from Brendan Schaffler, who's a program manager at Healthy Oxford Hills. Then we will be opening it up to questions from you all and have the panelists reflect on your questions. So please, as you're hearing from all of us today, please type in questions into the chat, and we'll get to as many as we can in the last half of the hour. So before I turn it over to Erica, I was asked to present some data to give you a sense of some ways that challenges we use in terms of defining rurality, as well as some data that you can be reflecting on the impact of health status in our more rural communities. So without further ado, first let's start with some definitions of rurality. So in this map here on the screen, you'll see there's actually two layers of definitions we use. One is population density, or people per square mile. That's represented by the blue shades throughout Maine. And then the second is a definition the census creates every 10 years, and that is urban rural classifications. And essentially the census goes through and defines two urban regions based on the density and the populations in those densities. And then everything else, all the other communities and census tracts are rural communities. And this latter definition is important because when we use that definition, Maine is the most rural state in the nation, with 61% of our residents living in rural communities. When we look at other comparisons, the second to sixth highest states, Vermont, essentially the same as Maine, but there's only two other states that have even more than half of their residents that live in a rural community. And Alaska, which has got the lowest population density, only has 34% of their population living in a rural community. So I think as we think about the challenges and the opportunities in terms of addressing health in Maine and in the rural communities across Maine, it's a little different than often what we think about from a population perspective. And I'm going to layer a third definition on this map, because unfortunately, most of the data that we have available to us, publicly available data, it's often the smallest geographic areas we have is data at the county level. And so these will indicate, I have some slides later on that show us the data on non-metro areas versus metro areas. But I wanted to point out, just highlight when we look at Penobscot County, which is a small metro county, there's an awful lot of that geographic area that's rural. And so it's hard to we can't necessarily differentiate the health status from the urban versus rural in those types of counties. But I do just to highlight the reality of when we think about those urban rural classifications, there's only 2 counties in Maine that have less than 50% of our residents in rural communities, and that's Cumberland and Androscoggin County. So something as we tackle these types of issues. Next, I just wanted to point out, certainly we all know social economic factors are foundational for health of individuals and communities. And so just to give people data to reflect on, the map shows us poverty levels by county, and certainly our more rural counties have a heavier and higher burden of folks struggling with living in poverty. The graph on the right is just to emphasize that some of our health outcome data we have reflects poor health outcomes among those. If you look at the bottom half of that graph by household income and by educational status, which is we know is so strongly linked to financial resources. This graph is presenting data in terms of the percent of adults who reported their mental health was not good in 15 to 30 days out of the past month. The patterns are similar if we look at physical health, particularly in the income and education levels. Certainly physical health gets worse as people get older. So, but when we're thinking about the social economic burdens, the patterns are similar. They're also similar when we think of higher rates of tobacco use in our lower income subgroups and lower education, and obesity, particularly those struggling with more severe levels of obesity. The rates are higher in those lower groups. So certainly the burden of health risks and in the rural areas is something that's a higher level we have to think about than in our metro areas. Third, I wanted to show you some health outcome data. This is shows you the leading causes of death by rurality groups. And again, I showed you those urban counties, the metro counties. So the non-metro compared to metro, again, the metro included York, Cumberland, Saginaw, Androscoggin, and Penobscot counties. The red font shows you where our rates are significantly higher in non-metro counties. The green is where they're significantly lower than in the non-metro areas versus metro. And you can see a lot of these chronic diseases, our rates, age-adjusted rates, are significantly higher in the non-metro areas. I also wanted to give you a comparison to the United States, just very quickly to show you that, to highlight, despite having metro areas having a higher rate of heart disease mortality than the metro regions, they are significantly lower than the US. Where we have significantly higher rates are for cancer, chronic lower respiratory diseases. That ties into our historically high use of tobacco, largely. Despite that there's not a difference in the mortality rates across Maine's metro and non-metro regions, drug overdose deaths is significantly higher in Maine. This data is only through 2020. That is getting worse. So that's an issue across all of Maine that we need to figure out how to tackle. And then finally, I wanted to highlight down towards the bottom, we have significantly higher rates of suicide. This is, so our behavioral health issues in Maine, these are importantly pressing issues, and certainly mental health has an impact on the physical health as well. So I wanted to show you just another graph showing change over time in suicide rates. And this is dividing out a little bit more into the metro areas. The micropolitan county in Maine is Kennebec County. So that is just one, but you can see over time, if you look at the red line versus the green line at the bottom, the difference that everywhere across Maine, suicide rates have been going up over time over the past 20 years, but that rate of increase is greater in our non-metro, in our more rural communities. And then as we also think about that issue, just to point out that we know our rates are higher, the suicide rates are higher among males versus females. But this graph shows you age groups within males on the left half side of the graph, and females, age groups within females on the right hand half of the graph. And it's really to point out that our suicide rates have been going up in all age groups, among our males in particular. It's often we think of this as an issue we need to tackle for young adults, and it's well beyond that. So it's just an important piece to think about. But also, finally, I wanted to show you how much greater those increases are when we compare the blue dots on the big increases for Maine going from light to dark in all of these age groups, and then compare it to the US dots. Substantially higher increases across all of our age groups. So with that, I'm going to stop sharing, and I will turn this over to Erica to hear your thoughts.
Thanks, Tim, for that overview and also for your kind introduction. Hi, everyone. It is a pleasure to be here with you virtually this afternoon. I am Erica Ziller, and in addition to being a faculty member at USM, I direct its Maine Rural Health Research Center. I'm excited to share that the Maine Rural Health Research Center is celebrating its 30th anniversary this year. And despite the presence of Maine in its title, our center has, for the most part, been very focused on the federal policy landscape and, to a lesser extent, what's going on with state health policy. And so I'll be sharing some remarks from that perspective, the big picture perspective, and leave others on the panel to talk more about Maine and their local communities. So in keeping with the broader theme of this year's conference of adversity and resilience, I've organized my remarks to start with some discussion of challenges that we've experienced historically at the federal policy and public health programming level, and then move in to talk about some changes that I've seen recently, which I think really hearken to some better opportunities for rural health and rural communities and rural public health going forward. So to the first point, it's, I'm sure, no surprise to anybody that rural communities have historically been disadvantaged in a lot of ways related to federal policy and public health funding. One of my dear colleagues from South Carolina, Jan Probst, refers to this phenomenon as structural urbanism. While it doesn't apply to the Federal Office of Rural Health Policy and to the Health Resources and Services Administration more generally, which funds our centers and all kinds of different rural health infrastructure projects across the country, this issue of structural urbanism is woven throughout federal policy response, and also to a large extent, our public health programming at the federal level. So what this means is that instead of focusing on investing in critical infrastructure, a lot of our federal policy has been much more focused on individual access concerns, such as expanding health insurance coverage. While things like the Children's Health Insurance Program, the ACA, are incredibly critical to rural communities, they are not sufficient to guaranteeing that there are going to be those resources available in those communities. So while we focused on expanding drug coverage through Medicare Part D at the federal level, how that was going to roll out, how rural communities would enroll in plans, like all of that wasn't as well thought through. The same thing holds true historically for a lot of public health funding criteria. Ryan White funding, for example, is based on the number of people in an area with HIV or AIDS. The CDC's community transformation grants have required service populations of at least 500,000 people. It's pretty hard, even if you're lumping lots of rural communities together, to get up to those thresholds. And so, given all of this, we've had a much more siloed approach to rural health at the federal level than I think has been warranted, and insufficient thought and resources. But moving to the brighter signs ahead perspective, certainly I've seen a marked change in the past 5 years. And whether this is from a combination of political awareness, some major publications that have come out documenting rural health disparities, whichever the case, it's very good news on the federal front and within that landscape for our rural communities. So since then, I would say the most major difference that I've observed through my interactions with the federal government and my funders is that there's been a huge increase in collaboration across the Department of Health and Human Services within different federal agencies. The CDC now routinely includes rural as a disparity population when it's doing its analyses, and has been working hard to make data more accessible and available. At our annual center director meetings, we now have representation from ASPE, from the CDC, from CMS. We're all there wanting to learn more about our research and to share what they're doing from a rural perspective. This has translated into a lot more increased funding, both for rural health research and also for rural health infrastructure development. And interestingly enough, this is coming from all different agencies. NIH actually has been working to expand its rural health portfolio and has reached out to HRSA to discuss, its RFPs and its approaches to collecting data, more focus on things like pragmatic trials, which are easier for rural communities to be part of. And then finally, with all of these changes that are going on and the heightened interest in both rural health and in interagency collaboration, within HRSA, we've seen some growth and interest in much more multidisciplinary work, particularly around the social determinants of health. And so now all of our rural health work, we're asked to be very focused on the impact of racism on health in rural communities, on LGBTQ plus health concerns. Our funders have been working much more with economic development and had funding to work with the Northern Border Regional Commission. And we're asked to look at things like social vulnerability, adaptability of rural communities to climate change and resilience in that way. So with all of these shifts and changing priorities, I think it bodes well for opportunities for reducing rural health disparities and having the federal support necessary to do that. And we'll turn this back to Tim.
Thanks, Erica. Really great thought-provoking information. Appreciate it. And just to plug, folks, send in your questions. We'll get to those momentarily. Next, we want to hear from Tom Judge. I'm going to turn slides back on. All right, Tom, you can go ahead.
Let me get myself off mute. Thanks, and thanks everyone for inviting me to be here. So just really a couple thoughts. So one, in following from the previous, that these various definitions of what is rural and the variation in measures and funding and how all of these pieces fit together, one of the things that we would, posit is that there isn't a standardized framework for how we should be looking at things. And we've always used, Robert Maxwell was a great thinker in the NHS back in the 80s. Don Berwick was one of his disciples, and you'll see all of this, woven through the Affordable Care Act. But we use these as a test that when we do anything, we have a standardized test of, are we meeting the needs in these quality domains? And I think, post the meeting, there's hidden slides that go into these more in depth. But I think that a common framework of understanding how we should be looking at things and measuring things is really one of the challenges around rural. So if you go to the next slide, there it is. Yeah. So I think this is where it's sort of why this is important, why this matters. So we would describe that there's always this urban-rural paradox, that where some of the most need is, if you think about the impact of need, it's in rural areas and the resources are in urban areas. So from a policy and a belief standpoint, if geography is destiny in medical care and health outcome, what are we doing to level a playing field to really think about that impact of individual versus collective need? And I'd say that one of the prime examples of that is elderly. Our rural communities are also our most elderly communities with the least amount of services to support, in a way, the elderly population gracefully living at home. And we don't have, and we're going to have even less congregate elderly facilities in any of our rural areas. And we've got plenty of examples around that as Maine. And so that leads really to the next three things, which I think all interact, that the ownership, the consolidation of decision-making, and the scale are all a challenge in all of this. And more where you live and work, this, I think, is the previous speaker's structural urbanization, is how you end up seeing the world on a daily basis. So more and more ownership and consolidation of decision-making has moved to our urban areas versus our rural. And, examples of that are in pharmacy, or in the hospitals, or in physician practices, or in transportation. So that when we take those sort of core pieces of infrastructure out of the rural area, the impact of this individual, the low density services versus the scale of services really has a higher weight in a way. And I think that sort of takes us to the next point of that the access, the infrastructure in communities of schools, of libraries, of all of those core pieces that bring people together are more and more fragile in our rural areas. We know that transportation, just to get to anywhere, to get to healthcare, medical care, pharmacy, is an issue. And while we've made some, gains, and we're making gains in increasing broadband access in our rural areas, there's still a huge technology gap. And I think that I think of this as taking us to this next point of that in rural areas, leaders, informal or formal leaders, are really wearing many hats. And so often their ability to do the kinds of things that are necessary when they're very stretched is a challenge. And an example of that is we're working with the ambulance services, of whether they were in network or out of network, which is a protection mechanism for the public. And basically in the rural areas, they're out of network because there's nobody that has enough time to file the paperwork. That the amount of paperwork necessary to get contract agreements in network with insurance carriers is just an immense amount of time. we saw this and we were doing a project to improve weather reporting for Lifelight. We got a bunch of USDA funding, 7 communities. It was about $77,000 in grants in total across 7 communities. The paperwork to do that, which was in those days still paper, was 22 inches high. And so in a rural area, the many hats, the people who are trying to do this just do not have the time to do that. So one of the things that I think we can do is think about how do we do this. So in the Rural Health Action Network on EMS side, we put together this informed community self-determination process about how communities can take on an issue. And I think sometimes we try to solve every issue, and if we solved one, that might give us some leverage to the other. We've had some real good experience. There's work on this in EMS going on, and I think there's more, can follow up to look at this as a process of how rural communities can regain control of sort of transparency, understanding the impact of decisions they make around services and what those will cost and what the barriers and opportunities are. So let me leave it there, and I'm sure there'll be plenty of time for questions.
Tom, thank you so much. Next, I'll turn it over to Sabrina, and we'll hear from what you're working on.
I apologize about the lighting in here. I think I have one of the sunniest offices in the building, but for some reason on this Zoom, it is rather dark. My name is Sabrina Keene. I work at Healthy Community Coalition in Farmington. We are a part of Franklin Memorial Hospital under Maine Health. And I give that piece of information because I think it gives us the unique perspective on our role in our county and within our community. So when I was asked to speak, I was really focusing on our mobile health unit and how that came to be, mobilizing our efforts to really increase access to care and connection. And I love this work. It gets me so excited. I think of ourselves as detectives. We basically get to research a problem and pilot solutions that best fit the need of our community members. And that looks different every year. I will say that with all this work, we are constantly asking those who are most affected, lived experiences, for their voice in part of those solutions. So I run a group called the Franklin Resource Collaborative, and what we do is we meet bi-monthly, and it's all social service agencies throughout Franklin County. And we talk about what are the main barriers, what is affecting our community members, and how we can all work together. I'm sure a common trend in community health, public health, is working in silos. So this coalition and this particular group, we work together to really bring in our funding sources and create solutions. One of that is by our mobile health unit. So we have mobilized our efforts in several different ways. We have several grants here at HCC that are forever changing, but we all take our work on the road. And I wanted to just shine some light on our COVID vaccine team, which has done almost 2,000 vaccines mobily, distributed over 9,000 COVID at-home testing kits. And 52% of our work is really community-based, on the ground, being out there, talking to people, which is really what it's all about when we're working with people and trying to find out solutions and getting that access to care. One thing I've noticed about Maine is it's very unique, and relationships really mean a lot to people here. So to get people to come to the table and to tell us the issues and their, real life solutions, it's not as easy as being awarded the funding. To me, that's almost the easy part, is writing in and describing the issue, but it's actually getting folks to the table and coming up with solutions together. So my main focus on the mobile health unit is harm reduction services. And since June, we were awarded a grant through the Maine Health Access Foundation. to do harm reduction services on the road, all throughout Franklin County. So once a week, we take our bus out. We have reached almost 100 people in recovery or currently using. And we offer things like Narcan, fentanyl testing strips, HIV and Hep C testing, and syringe clippers, pretty much any sort of service that can be of use. We're not a syringe exchange yet, but we are working on that. And that will also be mobilized. So recognizing that transportation is just a huge barrier in our community, we're going to take the solutions to them and see how that works. So far, it's been quite successful. I have noticed throughout our data collection when we're meeting with folks that we're really noticing the emerging adult population, so 18 to 25, are really open-minded to come seeking services and talking about their treatment option or what that could look like down the road. They're also very open about the reality of our communities and what they're seeing. So that, I think, is pretty amazing that we're getting real life data, talking to people and being out inside the community. We also have we look at gender and age range for general resources. And so far, 30% of our work for resource connection, whether that's connecting them to an outside organization or connecting them within our main health system, is mainly females, and that's okay. Like I said, the folks in Maine, they are really big on relationships and trusting. So we continue to show our faces and our presence, and that we're really there to help. So I will leave it as that. Thank you for having me today.
Great. Thanks, Sabrina, and thanks for all the work you do. It's incredibly important. I think there's a lot we can learn, particularly when we think about the issues that Tom mentioned. You broadband and other technology, where it is and isn't. How do we have to go to things like mobile health units? All right, so our fourth, last but certainly not least, Brendan, I would like to hear from you, and then we're collecting some good questions. So we'll turn it over to you, Brendan.
Great. Thank you, Tim. So yeah, I'm Brendan Schaufler. I use he and him pronouns, and just a caveat, I'm not showing up as my best self today. So I say that not to ask for your pity, but just your patience. I've got a lot on my head and my heart right now. So if you think, geez, this guy isn't as prepared or articulate as I expected, it's because I'm not, but I'm going to try to do my best for you. So in addition to being a chronic oversharer, I am a program manager for Healthy Oxford Hills, where the majority of my time is spent as the network facilitator for something called the Oxford County Wellness Collaborative. And that sounds like an IT job, but it's not. The network is built of people. And my job is really to facilitate collaboration, to figure out what people have a shared concern around in terms of community health, and then to support them in working smarter and not harder towards that mutual goal that they share. I've been doing this for about a decade, and the collaborative was born about that time ago, when there was this recognition that there wasn't a common space for people who had these concerns to kind of gather. So we had lots of people who cared about active communities and behavioral health and healthy food, but they weren't connected and talking to each other. So there wasn't the ability to share learnings, to share resources. And we were learning, there was this recognition that the folks in Rumford may have been struggling with the same things that the folks in Freiburg struggled with 3 months ago, but there was no acknowledgement of that, no connection there. So there was a lot of duplication of efforts and reinventing of wheels, and the collaborative was born to really try to overcome some of that. So over that decade or so, I've had the privilege of supporting a number of different constellations of folks on topics ranging from outdoor recreation to school gardens, to social emotional learning, adverse childhood experiences, resilience building, addiction and recovery, all sorts of different topics. And really I wanted to do today was just share some of the observations I have around the pros and cons of doing public health in a rural space, being a public health practitioner. And starting with the pros, I would say there's this incredible willingness and desire for collaboration in rural spaces. There's often this recognition that, like Erica said, we don't have the resources that many of our urban counterparts have. So there's a desire to make the best use of the resources that we do have. Experience, information, whatever it is, how can we share so that we're really making more progress together? And there's an incredible amount of connections in a rural space, right? Maine's a small town state, and in the rural counties, that's doubly so, right? So everybody knows everybody, which sometimes is a hindrance, but in lots of public health settings, it's a help, because you're wanting to make a connection with somebody. Likely you're at the table with somebody who already has that connection. And speaking of connectedness, we've found when we've brought people together we've helped facilitate the community health needs assessment processes for several years or several cycles. And when we have these conversations about all these different topics in community health, a lot of our community members, I would say the majority, have this appreciation of the interconnectedness of these topics. And I think even before the phrase social determinants of health was popularized, there was a recognition amongst a lot of our community members that so much is connected in terms of what's going on in our rural spaces. So to switch briefly to the cons, capacity, right? There's a huge issue. People, like Tom observed, the many hats going on in rural spaces. And if you've ever, if you're from a small town in Maine, maybe you know that the town manager wears many hats and is often the tax collector and the town clerk and the highway commissioner. And that's true in a lot of different roles in public health as well. There's lots of people wearing lots of hats, and it can be difficult to have them give the time that they want to give to work on these community health issues together. Rural approaches are sometimes poor fits, and I say that from the experience of having come into the world of public health, working on a lot of bike and pedestrian issues, and I was looking to not reinvent wheels and thinking, like, what rural settings have experienced success, and how can I import those strategies to Oxford County, which is a county of about 57,000 people. And the evidence-based work that I could find that really worked well in rural settings came from counties. So maybe they have 120,000 people, and they have a small city that's 40,000 people. And in Oxford County, our largest towns are 5,000 people. We have lots of towns that are just a few thousand people, and some towns that are a few hundred. So the evidence-based work that you're looking for elsewhere, you can't always import. The funding piece, and Erica alluded to this as well. It's difficult sometimes to draw the attention in rural settings, because very often funders want to go where they'll get the biggest bang for their buck, and that's often an urban place. So attracting the funding, and in particular, long-term multi-year funding, I think is a challenge to attract in rural settings. And then geography and transportation. As Sabrina said, it's hugely important to engage those people who are most affected when you're doing public health work. And we've long held to this nothing about me without me kind of ideal. So how do we bring community members in as often as we can for those conversations? And the geography piece makes it difficult to do that, right? Like, we know to offer to pay bus fare or Uber fare, but you can't do that when there are no buses and there's no Ubers. So getting people to the table to actually hear from them is difficult, even when you know the strategies to kind of overcome that, if there's not the infrastructure to help support those strategies. In many cases, the pandemic, the silver lining of it, as so many of us have found, has been that virtual gatherings like this allow us to overcome that, which is fantastic. And, one of the slides that I think Tim had that you didn't see was broadband is a huge, there's a huge lack of it right across so many spaces in rural Maine. So even when we have this ability to come together virtually, that challenge still exists for lots of us because of the lack of infrastructure. So thank you again. I appreciate your patience and your indulgence, and I look forward to the questions and answer. I'll turn it back over to Tim.
Thanks so much, Brendan. Very well spoken, and lots of great thoughts from all of you. So we have about 20 minutes. Let's see if we can get through a bunch of these questions. The first question, which I think is for me, I'll keep it very quick, and that is, what's the difference between poisoning deaths and drug overdoses? Poisoning is a slightly broader, the broadest category. It might include a young child who accidentally gets poisoned, but the vast majority of the deaths that could classified under poisonings are related to the drug epidemic, the drug overdoses. Another category to think of is that alcohol poisonings is separate from what we consider drug overdoses. So the second question, and this is for you, Sabrina, how has the housing crisis impacted the work you do? And are you serving unhoused persons as well as those in homes?
So Western Maine Community Action is our housing hub here in Franklin County. We currently do not have a homeless shelter in Franklin County. They are working towards getting one. The community input has been quite negative on that, of where it would be located. So it's been quite a challenge. So yes, I frequently work with people who identify as homeless or are couch surfing, especially young people. And most folks that are living in their car, one of their biggest issues is getting gas to come, here and there. I feel like I'm going far away from what the original question was. So if you don't mind repeating it, or I might have answered it all.
But I think you've answered it. It was related to, are you serving those that are homeless as well as? Thank you. Next, there's a question, and I think all of you could chime in some shape or form if you'd like. And that it gets to this the theme where there's folks who have multiple hats, and taking it to the next step of there's the formal leaders within our regions, but what about the informal leaders? And how do we engage and leverage action from informal as well as formal leaders?
I don't know, you want to
go ahead, Tom. Jump in.
I think that and this comes down to knowing communities, that often the structural leadership in a community is different than what may be the elderly leadership, the long-term leadership in communities. And one of the things we do know from research is that leadership in communities, especially multi-generational leadership in small groups of families, has a dramatic impact on the success of communities sort of across the board. So one of the pieces that normally we do is we reach out to the formal leadership, the people that are through the town office or have something by their name that says they're leader, and we forget that they may not be the most impactful people in the community if we're trying to reach past and to get to some of these very intractable problems. So finding those, and that's local knowledge, finding those informal leaders is incredibly important.
Great, thanks. I'm seeing nodding heads from Brendan and Erica and Sabrina, so I'm going to interpret that as you'd probably have a similar message. We get lots of other good questions here. So one for you, Brendan, what strategies are you employing to attract long-term funders to your rural areas? And I think then this, Erica, Sabrina, Tom, you may also have some ideas around this. So we'll start with you, Brendan.
Yeah, if anybody has ideas, I'd love to hear them. We know from working with a funding consultant that it's just difficult to attract long-term funding to support networks to offer that core capacity. Most funders are more interested in funding programmatic work, and that's difficult. So I don't know that we have an effective strategy for attracting that long-term funding. I will say that we're fortunate in Oxford County to have this long-term multi-sector collaboration called Maine West going on, and it's funded by Betterment, and it's built on the legacy of a long-term partnership that was in the conservation sector. And Betterment said, well, what would happen if we brought people together and folded in economic development, education, and health and wellness? And they've invested 10 years of funding in that experiment to understand what happens when you bring those people together for that sort of multi-sector collaboration, which is fantastic. And we're in the 7th year of that collaboration. We're seeing really interesting things come out of it. And Betterment had the wisdom to stipend the partners who are participating, to kind of elevate in priority how they show up as members of that multi-sector collaborative. So it's not just another hat you have to don, but it comes with some funding to kind of, like I said, elevate that priority to show up at those meetings and to do that work. And I think it's a really fascinating model, and I'd love to see it play out in other places in Maine as well. I think there's a lot of value inherent in it, and we're hoping that it will last well past the 10 years. A colleague in a recent meeting of Maine West said something which I thought was really profound, which is short-term funding yields short-term results. And I think that's incredibly true. And it's difficult, I think, for a lot of foundations to feel comfortable sinking long-term funding into one place. But I think we need to encourage them to roll the dice with that sort of experimentation and to really think more about that long-term.
Great. Thanks, Brendan. Any others want to weigh in on that?
Yeah, sure. I think that one of the pieces to that is, and you're seeing some work in layering and blending of funding amongst grant makers, but because the grant makers don't have a common framework for how they're looking at what they're going to measure and impact, I think that this is where you end up doing this. And so each grant becomes, I'll do the reports for this grant, but I haven't built any capacity or infrastructure to get to the next grant. So I think there's some, Baileyville, the hub in Baileyville has, I think, done some good work around this. I think MEHAF and Bingham are beginning to think a little bit about how you layer and blend funds, but that's really one of the issues as well. To hear from Brendan, I mean, I think Betterment has had some great work, and I think that's exactly the kind of thing that we need to do.
And I don't want to leave this question without acknowledging that the Wellness Collaborative has benefited from multi-year funding from a number of foundations, Sewell, Bingham, and Betterment, MEHAF as well. But over the years, their priorities need to shift elsewhere, and we're looking at the best way to kind of package our work into kind of programmatic chunks that we can invite investment for.
Thanks, Brendan. Somewhat related to that, and that is, we've heard from you, Brendan, in terms of some of the successes, and that's largely because we've had some long-term support financially, as well as the informal support and resources in the areas. But from you all, are there some strategies you could share in terms of convening collaborations in Maine's rural areas that may have less resources or not yet have established kind of some of those fundings? That's a tough one.
So strategies for kind of community engagement in places where there are less resources?
Yes. Yep.
Yeah, I'll share one, and maybe this is too far in the weeds, but often we learned a while ago that we really need to offer childcare if we're going to ask people to show up to meetings. And we've had tremendous success in partnering with some of the local out-of-school care organizations whose care providers are all background checked and thoroughly experienced and really reasonably priced for their time. So leaning into that for childcare, or our local tech school also has a childcare program, and we've used providers for that. Or we're a department of the local critical access hospital, Stevens Memorial Hospital. They offer a safe sitters class, getting people who come out of that. So that's just a very kind of practical in the weeds example of how to support that sort of engagement. As much as we can, we try to offer meals as well. And there's lots of really affordable ways for us to do that, we've found over the years. There are lots of different, I think, willing partners who want to support that sort of community engagement in rural spaces. It's just a matter of knowing your community really well to figure out where you're going to get the biggest bang for your buck with people who are sympathetic to that sort of engagement too and want to support it.
Great. Thanks, Brendan. Erica, turn to you to take it a little bit higher level. There's a great question. Should we be pushing for more sustainable support from governmental agencies as opposed to just our philanthropic friends?
Yeah, I would say yes. And I have some belief that, there's recognition among at least some of the federal agencies that this is essential. I mean, of course, this isn't a great example because our Portland roads have all kinds of trouble, but if you're driving in our rural communities and, going over the roads and you see how they've deteriorated over the past several decades, our public health infrastructures and other supports for rural communities have likewise decreased and deteriorated. And it's really hard to sustain any of this without a huge influx of resources at the level of the federal government. I just don't think communities as full of grit and goodwill and creativity as they are can compensate for just some of the real struggles economically and on the philanthropy side that rural communities have faced. So unless big organizations like the federal government, like state governments are there with those resources, I think it's going to be challenging.
Thanks, Erica. And moving away from funding, Tom, there was some conversation you and I had preparing for this meeting, but what are your thoughts on how we leverage some of the common resources in rural communities that may still need to be knit together? And have you seen experiences for that?
Yes, so I think that it's back, and we at the Rural Health Action Network, we did a white paper on this idea of informed community self-determination, and in that case we were really looking at emergency medical services, and we used that process in the 5 little peninsula towns, the villages that make up the town of St. George on a peninsula here in mid-coast. And, we saw that the services, the EMS service was just gradually, as we ran out of volunteers, that, we were just diminishing and diminishing. And it really took a solid process to get the town to understand what was at stake and to really do a bunch of work around that. But having done that work, what we found is that when it came to the schools, that same kind of work that had been done in this community process, then let that community think about schools in a different way, and then that each one of those projects layers together. So, and I think that we've seen in that community where there's much more integration across the business community, the faith community, the schools, that you begin to see, one piece layer to the other. So I think there's some processes that people have to go through that get you there. But then I think we can get this social knitting to be much tighter across the community.
Great. Thanks, Tom. Oops, sorry, went on to mute. Question for any of you. What do you think the rural health workforce will look like in 10 years? Erica, from a policy standpoint, do you have any thoughts?
That is a great question. And I am not a student of workforce, so I'm not 100% sure. I will express some concern, maybe not as much for Maine, but for other rural communities across the country about their public health workforce, because we know there have been a lot of huge declines, and the politicization of the pandemic in some communities has driven people, right out of the field and out of their communities altogether. I think some stats are 25% of the rural public health workforce kind of abandoned ship out of threats and just general unpleasantness in their communities. So I think one of our most critical needs is to try to figure out how to bridge this rural urban communication divide, and understand how, and this is where the work that Sabrina and Brendan are doing is so critical. Like, how do we bring public health, which is a more urban model, into rural communities effectively with understanding and trust on both sides? So I have a little bit of apprehension and fear for the public health workforce. And in terms of the general workforce, I really don't know what it's going to look like. Would love other thoughts.
It's going to be thin, right? I think that's one of the thinner is going to be the word. The United States is years behind some other countries that are very, very rural. So Australia, as an example, is probably a decade ahead of us in thinking about what do the professions look like, all professions look like, as you look at the 25-year demographic trends and doing this. And this gets into scope of practice. It gets into expertise versus profession, professional designation. And I think that we're rethinking that. I think that the Rural Health Transformation Team at the state level, we're beginning to think about that a little bit, of how do we do this? Do we, who's a physician? Where's a bed? Who's a nurse? What is expertise? It's interesting. The American Colleges of Optometry just figured out they were never going to solve river blindness in Africa by training more optometrists in Africa. So they just took the entire curriculum, put it online. Anyone can access it. Anyone in the world can access all of the curriculum to be an optometrist. And you're going to build this expertise without necessarily this professional designation. So I think that in rural areas, we're going to have to completely rethink how we look at these ideas of professions and who does what, and think about the role of expertise.
Great, thanks. We have 3 minutes left, and being a data lover, I have to switch back to, and Erica, you may have to help me with this. There are a couple questions you're asking in terms of the most reliable data. That may be something we can put together afterwards and send out. But one question is, to what extent is there sub-county data based on rurality? So we can look at health disparities based on geography.
Well, I can certainly answer from somebody who tries to do this work all the time at the national level, and there's very little. And there has been a huge trend among, national data sources and federal agencies to restrict data more and more. So data sets like the Medical Expenditure Panel Survey used to have a rural urban variable in its public use file that was completely at the national level. We couldn't know state, and it was based on county. They've removed that, and you can't even get access to whether a person in this 40,000 person survey lives in a rural or urban community. And there have been similar experiences. So it's very challenging. Even the BRFSS, we can get those data sometimes, but we have to jump through hoops to do so. So this is a pet peeve of mine professionally that I could talk about forever, so I'll stop.
Thanks, Erica. I would just one thought I have, challenges that we look at public health data versus are there some data that's in processes where we can utilize EMR and medical record data that may help us get to a little bit more granular level in a respectful way, and maintaining privacy and things. But that the challenge there is that we need to figure out how do we pool all that data. So I think we are 1 minute out. And I just do want to highlight too, if people didn't see Sabrina's comment, in terms of the role of community health workers. Her prediction is that will increase as the role really focuses on meeting people where they are, which I love. I think it's a fantastic point. So, and I think that kind of is perhaps a good place to stop as we reflect and think about how we meet each other where our needs are, as we think about how we can maximize and leverage resources and each other in terms of rural health, being the most rural state in the nation. Perhaps we can figure out ways with Maine's grit and that we start leading the nation in solutions as well. So I want to thank everyone, particular panelists, most appreciative of your thoughts today, your comments, your wisdom. Thanks for the great questions. I do think there are a few in there that we didn't have time to get to that we can try to tackle offline. So with that, Becca, should I turn it back over to you for any closing comments? Thank you.
Yeah, thank you, Tim, for moderating such a great discussion. And thanks to Tom, Brendan, Erica, and Sabrina for your perspectives and sharing your work and experience as well. And thank you to everyone who offered such thoughtful questions in the chat. So that does conclude this afternoon plenary, and I want to just thank you all again for joining us. We hope you enjoyed this discussion. Please remember to complete the session evaluation, which is right where you are. You just click that link, you should be able to access it. I also put a link in the chat. Our next session, Supporting Families Growing Together, will begin in about 9 minutes at 1:40 p.m. So we hope to see you back here then. Thank you.